Hello and welcome to today's UPMC virtual webcast event. As a reminder, during today's virtual event, you may submit questions for our presenter at any time by typing in the Ask a Question box below the video window of your webcast screen and clicking the Submit button. These questions will be answered after today's presentation. It is now my pleasure to introduce today's presenter, Dr. Jorge González-Martínez. You may proceed, sir.
Good afternoon, everybody. A pleasure to be with you this afternoon. My name is Jorge González-Martínez. I'm a neurosurgeon at University of Pittsburgh Medical Center, and I'm specialized in epilepsy surgery and functional neurosurgery. For today's talk, we will discuss about treatment options for epilepsy, and specifically we will talk about epilepsy surgery. So I will share my slides. Very good. The title of our talk and what we will discuss in the next 30 minutes is about game-changing surgical options for seizures and movement disorders. The first aspect of this presentation is for us to understand what are the three principles of epilepsy surgery. That means when we would like to indicate epilepsy surgery or when epilepsy surgery is indicated. First of all, the first most important principle is what we call the medical intractability for epilepsy. So patients, they should be considered medically intractable. We always try to control the seizures first with medication. And when the patients, they fail 2 or 3 medications, in general, the chances for patients to become seizure-free with additional 3rd, 4th medication is extremely low. That is the time that we consider those patients to be medically refractory. And this is one of indications for epilepsy surgery. The second important aspect is we need to make sure that the patients have what we call focal epilepsy in order for them to become or to be surgical candidates. Epilepsy can be generalized. That means that the seizures are coming from every aspect of the human brain, or they can be focal. That means that there is a specific area in the brain that is causing the seizures. In order for the patient to be a good surgical candidate, in addition to be what we just mentioned, medically refractory, those patients, they need to have a focus. The seizures, they need to be originating from a specific area in the brain, so we can go ahead and operate or treat that area. And the third aspect of this indication, or the principles of epilepsy surgery, is that this area in the brain that is focal and we will need to resect, remove, or treat, it needs to be safe to be removed or treated. So that means that we need to make sure that this area in the brain that is causing the seizures is not responsible for any other function like motor, sensory, speech, or vision. So those are the three most important, the three principles for epilepsy surgery. Medical intractability, number 1. Number 2, focal epilepsy. And number 3, the surgery or the areas that we need to treat, they are amenable for treatment. That means they're safe to be removed or to be treated. In order for us to make the diagnosis of focal epilepsy, there are several non-invasive methods that we perform. The first method, again, is what we call scalp EEG monitoring. This scalp EEG monitoring is the recording of the electrical activity of the human brain, so we can localize what we mentioned to be the epileptogenic areas. We can see, as you can see this in this slide, you can see this is an example of scalp EEG. You see the activity, the pathological activity that is occurring in a very, very focal area in those contexts. So this is what we're looking for when we perform EEG testing. And this is a procedure that in general takes a couple hours, or many times we need to admit the patient to the hospital and perform what we call a video EEG, when we record the seizure activity on the EEG, as I'm showing here, plus the semiological features, the type of seizures, the behavior during the seizures, which is also very important for us to localize the seizures. So probably the EEG monitoring is the most important non-invasive test that we do in order to identify if the patient is focal or not. In consequence, to identify if this patient is a surgical candidate or not. The second most important non-invasive data that we acquire during the evaluations of possible candidates for epilepsy surgery is MRIs, brain MRI. A brain MRI will identify different types of lesions that can be associated or not with seizures, and can also not identify any lesions. Both situations, in both scenarios, the patient can be still a surgical candidate. When we see a lesion on the MRI, the prognosis is perhaps a little bit better because we can identify the areas in the brain that are mostly associated with epilepsy, with seizures. So in that way, the work of seizure localization becomes much more straightforward. When the MRI is non-lesional, still those patients can be considered for epilepsy surgery. However, the work of localization, for me to know what areas in the brain are responsible for the seizures, are much more complicated and requires additional tests. There are several different lesions that can cause epilepsy. The most important lesion are, or the most common lesions are, what we call hippocampal sclerosis, which is a scar tissue located in the hippocampal formation in the temporal lobe. Other lesions associated with epilepsy are malformations of cortical developmental, also called cortical dysplasia, which are congenital lesions that are highly associated with epilepsy and many times present themselves as very subtle lesions on the MRI or no lesions at all. The third group of pathologies that we see very commonly on the MRI are tumors. And there are very, very specific types of tumors associated with epilepsy. Tumors like gangliomas or DNETs are very commonly associated with epilepsy. Vascular malformations, for example, AVMs or cavernous angiomas, can also be associated with epilepsy. And head trauma, strokes, something we call encephalomalacia on the MRIs, can also be associated with epilepsy. In this slide, we can see an example of two tumors. The top is an example of a DNET, and the bottom is an example of a ganglioma, both highly associated with epilepsy. As I mentioned, vascular lesions can also be associated with epilepsy. And here is an example where we see this small lesion located in the frontal lobe, most likely a cavernous angioma, which is also highly associated with seizures in this case. When we have good localization of the seizures, for example, we have good scalp EEG that points to a specific area in the brain, very clear behavior, semiological features, and an MRI that points to a specific area. We have what we call the definition of the areas that we need to treat. And this is what we call the epileptogenic zone, that may involve the lesions and also associate with other areas in the brain. However, when we don't have clear definition of where the seizures are coming from, even with non-invasive data, when we have the scalp EEG that shows that the results are not so clear for us, or an MRI that does not show any lesion. Additional surgical treatment is required not for the treatment, but for the diagnosis of epilepsy. We needed to better localize the seizures since we were not possible to do that with no invasive data. This is the point that invasive monitoring is indicated. So invasive monitoring there are different types of techniques and surgical procedures which goals are to better localize the epileptogenic zone when the non-invasive data cannot provide this very precise localization. In this case, the indications for invasive monitoring are when there is what we call discrepancies between clinical and anatomical data, when the patient has one type of seizures and the lesion shows the lesions are located in other parts of the brain. So there is a mismatch of what the seizures they look like they're coming from versus where the lesion is located. In this situation, this clinical scenario, invasive monitoring can be indicated in order to clarify the location of the seizures. Another possible indications is when we have multilobar ictal discharges, when there is a suspicion that the seizures are coming from different areas in the brain, and you want to confirm or not if this is truly focal epilepsy. In that way, make sure that there is a surgical indication for this scenario. And the third is when there are the impression that there are very early involvement of functional areas in the brain associated with seizures. So in that way, we need to know precisely where the seizures are originating from, the areas responsible for the function, and in that way, the surgeon can perform what we call a tailor resection, when we just remove the areas in the brain or treat the areas in the brain responsible for the seizures without touching the areas responsible for other functions, for example, vision, motor, sensory, and speech. The goals of invasive monitoring that way is, again, to localize the epileptogenic zone, the areas that we need to treat, to localize the functionally important areas in the brain, and finally, to perform and to guide the surgeon for resection, a safe resection. In the United States, for many years, we use as a method for invasive monitoring a technique named subdural grids. And this is an example of a subdural grid implantation that involves the large exposure of the human cortex and the implantation of superficial electrodes to perform the mapping that we need in order to perform, again, understand what are the anatomical areas in the brain responsible for the organization of the seizures, and also the functional areas that we need to preserve. So for many times, the subdural method was a reliable method of functional mapping and superficial cortical map. And this is an example of how we perform invasive monitoring using subdural method. This is an example of a 3-year-old child with motor seizures. The scalp EEG shows activity coming from the motor areas on the left side. And the MRI shows, this is the sagittal view T1 MRI, shows a potential lesion. Here, most likely a malformation of a cortical development. The challenge in this particular scenario is that we have this lesion that is located in a very important area in this child's brain, which is precisely between the motor and the sensory strips. So the surgeon really needs to understand what areas in the brain we need to treat in addition to the lesion, and also to have a very precise idea where is the motor and the sensor areas, so we can perform this safe resection and also very efficient resection. So that's the reason in this case we implant this grid with high definition just on top of the areas, the motor and the sensory on top of the lesion. This is an imaging of the reconstruction of the grid in relation to the anatomy of the lesion. And using this, we perform now what we call the functional mapping, which is the location with the grids. We can pass little tiny electrical currents where we can now precisely localize what are the areas in this child's brain responsible for the hand movement, the areas responsible for the sensory feelings, and the areas responsible for the seizures. In that way, we can perform now a tailor resection when we just remove the lesion and the areas responsible for the seizures. In the subdural grid provides very high definition of the cortical areas with a functional mapping, but there are some disadvantages. The main disadvantages, as you can see, is that this is an invasive procedure that requires a large craniotomy. And this is a challenge for the field in the past. That's the reason why, perhaps 10 years ago, we brought to the United States a new method, or we developed a new method named SEG, where instead of implanting electrodes through the craniotomies, we perform the implantation of those electrodes through little tiny pinholes in the brain. And most commonly, this procedure is performed through very sophisticated device. This is a robotic arm that can provide very, very clear guidance of the implantation of electrodes through small percutaneous implantations without the need of large craniotomies, as you saw before. So the field of epilepsy evolved very clear from invasive methods to less invasive or minimally invasive methods. Now, with this technology, we can implant small electrodes, we can localize the areas, and we can also use non-invasive, less invasive methods in order to treat the areas. And this is an example of what we call SEG-guided laser ablation. We perform the localization of the seizures through those percutaneous electrodes. And then once we found a small area in the brain, we can perform a thermal ablation through laser. And this procedure is normally performed under MRI live visualization using a technology named thermography, where we can now know exactly what is the changes in temperature when the laser is on and predict what will be the size of this lesion live and have, in consequence, very good outcomes and very safe outcomes. Here are some additional pictures of how we perform a laser ablation or SEG laser ablation. In general, this is performed using the robotic device that I just mentioned to you. The robotic device will guide the implantation of the laser catheter. This is the point where we insert the laser catheter into the structures that we need to treat. And then once we do the ablation, this is what we normally see, a small one-stitch incision, patients going home the next day. So this is the new phase of epilepsy surgery, going now from a more invasive aspect, as I showed you before, to a more less invasive effect, showing very good results with very good localizations and seizure outcomes and also safe results. The main advantage of this procedure is truly how minimally invasive it is. This is an example of a child that we perform with laser ablations. You can see the implantation of the bolt with a laser during the treatment. And this is truly the only scar that we see, a small 4-millimeter incision that is almost imperceptible. So we normally perform this with a small incision. We perform a small opening, 3.2 millimeters opening the skull, and then we perform the implantation of the electrode. This technology allows us to do the confirmation of the target before ablation, and then there is an automatically on and off. So the surgeon has a completely control of how big or how small the lesion will be under live visualization. And most importantly, the effects are immediately. So we see that there is an ablation, the seizures will decrease immediately or stop immediately. And also for last, there is a minimal hospital stay, as I mentioned before, where the patients, they only stay for around 24 hours or so. It's important here that this technology, and again, I mentioned to you about the thermal coagulation, that we know exactly what are the effects in the tissue depending on the temperature rise in the areas that we need to ablate. And we can monitor that temperature second by second. So here we have the normal temperature, 43 degrees Celsius. That means fevers, and we don't see any permanent damage to the human brain. When we raise the temperature up to 59 centigrades, we have the death of the cells that depends on the time of the exposure. And when again we go all the way to 60 or above, we have the immediately coagulation of the tissue and death of the tissue. So based on the response of the tissue in relation to the temperature, and the fact that we can see the changes in temperature live, we can perform very precise ablations, very predictable ablations nowadays. Here are two examples of ablations that we perform. A patient with a 2 seizure foci, localized using SEG method. And this is the ablation that we perform. We treat this patient without the need of a craniotomy, with the 2 ablations located in the frontal and also in the insula on the left side. This patient is doing very well. From a illustration point of view, I will show you how we perform this procedure. You can see here the movement of the robot. We use the initial robot in order to perform the registration of the head. We use a laser technology. You see how the robot interacts with the surgeon. This is the laser that maps the face, so it registers the areas. We are now performing the automatic registration, so the robot can understand the position of the head in relation to the MRI. So this process, it takes approximately 5-10 minutes. Once we do this, we prep and drape to preserve the sterile environment. We implant adapters that can guide the position of the laser precisely. Once we perform the registration and the implantation of the adapters, the robot guides the trajectory of the laser ablation. This is the point where the robot locks into the right trajectory. Now that's the point where the surgeon performs the small 3.2 millimeters opening in the skull. We drill this through the drill. It goes through the skin, the bone, and the dura. Small incision, small opening. Once we reach the areas, we will use specific instruments that will open all the layers, the dura in this case. We insert the guiding bolt, which is going to guide the position of the final probe, the laser probe, to the final target. So once the bolt is implanted, we will insert the laser ablation catheter. Just going to go through here. And once we have the bolt placed, we are going to again connect the devices, the laser ablation. And this is the laser ablation device, the probe. We insert initial robot that is going to drive the implantation of the probe. You see how the drive, it moves up and down, so it drives down the probe implantation. And here you see the final laser catheter. This is the moment that the surgeon inserts the laser catheter in place, guided by the robotic device. Once we finish with this step, we will bring the patient to the MRI. This is the time the patient will go inside the MRI, and here we take pictures from the MRI. You see now the live visualization, the confirmation of the catheter in a specific location. So it is a very, very safe and precise procedure. Once we confirm that the catheter is in the right position, we will perform the ablation. And here are the images of the thermography. When you see in a few minutes the emergence of the changes in colors over here. And you're going to see a yellow line that shows the extension of the lesion live second by second. So once we perform the lesion that we'd like to, in a very predictable way, we remove the catheter, put a stitch, and the patient will go home again in 24 hours. This is an example of a patient that will perform SEG-guided laser ablation. This is a 17 years old boy that has several seizures per day. This is the time that the seizures started. You can see here the movements of the trunk. He wakes up, he looks, this is the seizure semiology. This is the type of seizures that he has. Look around. Sits. And the final scream. So very debilitating focal epilepsy, refractory to medications, MRI, non-lesional. That's the reason why we perform an SEG exploration and invasive monitoring. And this is the images of the SEG localization. This is the position of the electrodes. And here we can see here the very, very clear localization that we obtain located in the superior frontal gyrus on the left side. Because this was a small area, we decided to treat this patient with a laser ablation, a SEG laser ablation. This is the final results with MRI, showing the lesion, a small lesion located on the frontal. This patient has been seizure-free for more than 7 years. This is an example how the field is moving from a more invasive to a less invasive when we completely made the diagnosis and treatment of this kid without the craniotomy, just by percutaneous techniques, and he's doing very well. Our outcomes for seizure freedom are around maybe 50 to 60%. We're still working to improve those outcomes and understand this very complex pathology, but we feel that our results are very, very appropriate, and what is most importantly, with a very low rate of complications. When the patients are not considered to be surgical candidates for the criteria that I just mentioned to you, for example, because the areas in the brain are located in areas that we cannot, the seizures areas are located in areas that we cannot remove because those are eloquent areas, we have other options that not resections. And those other options are, for example, brain pacemakers. This is an example of a patient with a malformation of cortical development with focal seizures located in the primary motor areas. This patient was resected initially, but continues to have seizures. But unfortunately, further resections for him will probably result in a permanent neurological deficit. So he's not a good surgical candidate for resection. However, he could be a candidate for what we call brain pacemakers. And this is what we did for him. Using the SEG method, we implant 3 electrodes where we localize the seizures, but we could not resect. And those are pictures of the implantation of the RNS system, the response neurostimulation, showing the intra-op implantation with implantation of the electrodes. And this is a final imaging that we see intra-op with the presence of the pacemaker and the implantation of the electrodes. Those are smart devices where those devices are able to detect the seizures at the same time to trigger a small electrical pulse designed to stop the propagation of the seizures. And this is a palliative method that we can apply for patients that are not considered not surgical candidates for the reasons that I mentioned before. This is another example of a patient that has bilateral hippocampal sclerosis, scar tissues on both temporal lobes. So by definition, this patient cannot be a good surgical candidate because of how extensive the epileptogenic zones are located, because they're involving both hemispheres. So he becomes, in consequence, good surgical candidate for neuromodulation for, in this case, neuropace. And in this case, we perform the implantation of the electrodes on both mesotemporal structures. And here is the final position of the electrodes connected to a pacemaker that is implanted in the skull. When we go back and review the results of neuromodulation, it's important to understand that the neuromodulation is designed for palliation. We are not intending to completely stop the seizures. However, we could. But in general, those patients, they have improvements in seizures. And this improvements, as you can see in this graph, improves over time with more optimal results over time. So this is a technology that we normally apply, again, for patients that are not considered to be surgical candidates. So in resume, I'd like to close today to say that epilepsy surgery is a moving field. It's an advancing field that we saw in the last 10, 20 years, a lot of exciting updates, moving the field from more invasive procedures to less invasive procedures, providing similar outcomes or better outcomes with less complications. Of course, the future will bring new technologies, for example, the brain pacemakers that I just mentioned to you, but other methods like focused ultrasound that will help to even implement even further the results of epilepsy surgery. With that said, I'd like to thank you for your attention. I'd like to also to thank the members of the UPMC team to help us to put this in place, Kate, Ryan, and Chris, and I would like to open for questions. Thank you. And here are the questions. Yeah. All right. So let me go through some of the questions that we saw in our website here. in our chat. Question number one is, does having seizures means that I have epilepsy? And again, seizures, they don't mean necessarily that you have epilepsy. But by definition, if you have several seizures, if you're always having seizures, recurrent seizures, this is the definition of epilepsy. So one seizure is not considered to be epilepsy, but when you have several seizures, recurrent seizures, this is what we consider to be epilepsy, the diagnosis of epilepsy. Okay. Second question is, what does the recovery look like after surgery? Is physical therapy or occupational therapy necessary? Very good question. It depends on the areas that we operate. In general, the patients, they stay in the hospital maybe 2 or 3 days after surgery, and in general, the time of recovery goes from 2 to 3 weeks. Again, depending on the locations, the areas that we need to operate or need to treat. Also, is the indication or not of physical therapy after. If we're talking about areas that are far away from areas important for the functions in general, physical therapy is not necessary. But if we need to operate in areas in very close proximity with motor areas or sensory areas, many times patients will go for a phase of physical therapy after. Again, it depends on the location of the seizures that we need to treat. The other question are, what is an epileptic syndrome? Epileptic syndromes are, every epilepsy is linked to a syndrome. So that means that epilepsy by itself is not, seizures by itself is not the cause of is not the disease itself, it's a symptom. Associated with those symptoms are the etiology, the causes for that. So for example, if you have mesotemporal sclerosis, the scar that I show you in the temporal lobe associated with seizures, this is a specific syndrome in epilepsy. If you have tumors and seizures, this is another syndrome. If you have, for example, malformations of cortical development associated with other congenital malformations associated with seizures, this is another type of syndrome. So again, when doctors, they mention about syndromes, that means they're a combination of different etiologies, or specifically etiologies causing specific symptoms, and that's what we call syndromes. Are seizure disorders hereditary? Very good question. Most of them, they're not hereditary. They're sporadic. They may be linked to genetic components, but they're not necessarily hereditary. The vast majority of those of patients that we treat, they cannot transmit the seizures or the issues or the pathology to their offspring. So in general, they are not considered to be hereditary. Would any of these surgeries be appropriate for someone with Gibbon syndrome? It depends. It depends on the features. I think in order to answer the questions, I would recommend you to look for a specialist, contact us. It's a very individualized. Some of those Gibbon syndromes can be surgical candidates, other not. It depends on the features of the seizure. So I would probably report to one of our group or to reach out to us in order for us to make a good recommendation for you. Do either surgery works for this cognitive epilepsy, abnormal deep white matter, and chronic parietal lobe hemorrhages through the ECG proof diagnosis? Yes, eventually yes. So depending, again, the surgeries can work for seizures, depends on the location, the etiology. So again, every patient is different. They're very individualized in terms of treatment. So I recommend you to come to our specialists so we look at you, we'll assess the type of seizures and make the right recommendations for you. They can be treatable with surgery or even with medication. That's what we need to identify or define. More questions we have is, are seizures disorders linked to psychiatric disorders or depression? Very good question. And yes, very commonly, epilepsy is linked to mainly the depression. And we see that quite often. The depressions after surgery, in general, they get better. In some patients, they can get worse, but overall, they improve over time after the treatment of seizures. So again, that's the reason why we have many times a psychiatrist in our group in order to really treat those patients with psychiatry-associated psychiatric disorders, mainly depression associated with epilepsy. The next question is, are there coexisting or pre-existing conditions that could rule somebody out from having epilepsy surgery? In general, the most majority of patients are not surgical candidates. Remember, I told you in the beginning that the three criteria to become surgical candidates are medically refractory, focal, and safe resection. So the vast majority of patients, almost 70%, will have their seizures controlled with medication. Only patients that cannot control their seizures with medications are considered to be surgical candidates. So yes, the vast majority will not go for surgery. Is epilepsy surgery available for pediatric patients? Yes. And in fact, most of the epilepsy surgeries that we perform are in pediatric patients. It's important to understand that seizures, we need to treat them as soon as possible, mainly for adults, but also very likely for kids. The sooner we treat the seizures, the less consequences those seizures will have for social and also neurological conditions. So I recommend to treat pediatric patients with seizures as soon as possible, and with very good results in general for pediatric population. After surgery, we'll be limited in any activities like driving or working out. In general, there is a limitation for working out or exercise. In general, we ask the patients to stay out of the exercises for maybe 3 or 4 weeks in order to promote nice healing. After that, they are free to perform any physical activities. Where do you do surgery? At what hospitals or hospitals? Okay. In general, epilepsy surgery is done here at University of Pittsburgh at Presbyterian Hospital. You will have a contact about our center, but all the epilepsy surgery procedures that we perform are mainly here in Presbyterian Hospital in Pittsburgh. I live out of state. Can I have a virtual visit with you or your team before traveling to Pittsburgh? Absolutely. You will have my contact, and I'll be happy to contact you about this visit. We see many patients on Keppra for seizures. Is that a standard form of treatment before any surgery is warranted? Yes. So again, the first alternative, the first option here is medical treatment, and Keppra, it's a very common medication that we provide for many patients as a first order medication. So yes, in general, we start with Keppra or other types of medication, but Keppra is very, very common. Can traumatic brain injury cause epilepsy or seizure disorders? Yes. As I mentioned in my slides, one of the causes for seizures are strokes and trauma that can cause scar tissue in the brain, and they can cause seizures. And those seizures in general are first to treat with medication. If not, they're amenable for surgical intervention as well. And I believe this is the last question, is how long is the overall process for epilepsy surgery for testing through surgery? In general, this process of acquiring the information, the non-invasive information, the consultations with neurologists and neurosurgeons are in general from 3 to 4 months. So once we consult you, we will request the tests that are necessary, a possible MRI, EEG, and then a consultation with our surgeons. Before any procedures, we like, again, to make sure that we cannot control the seizures with medication. This is the first line of treatment. And if not, we have what we call a patient management conference meeting, where we all get together. We discuss the possible candidacy for surgery and what types of surgery. And only after that, the surgeon will be contacted, and then we will see me, and we will decide what type of surgery and when we will perform the surgery. This whole process takes around 3 to 4 months to occur. And I think we went through all the questions. So again, I'm very honored to be here. I hope this was very informative to you. And if you have any further questions for us, please do not hesitate to contact us in our website, and I'll be happy to talk more about the details and about other options for epilepsy surgery. With that said, thank you so much, and have a good afternoon to all.
Thank you for attending today's UPMC virtual webcast event. You may now disconnect your webcast line and have a pleasant day.